Slower.
Small box ಕೊಡ್ತಾಳಾ? Small box ಕೊಡ್ತಾಳಾ? அப்ப இதை ஆஃப் பண்ணிடுறேன். முதல்ல என்ன ஆரம்பிச்சு அதுல போடுறேன். ஹெட்ஃபோன் வச்சுட்டு இல்லையா ஆகிருக்கு. அதுல லிங்க் இருக்கு. இத போட்டு
Please come here. Hello.
இது மட்டும் சார்ஜர் மட்டும் கேளுங்கய்யா.
இப்போதைக்கு தான் நான் டவுன்லோட் பண்ணிட்டேன். இன்னும் ஸ்டார்ட் பண்ணலன்னு நினைக்கிறேன் யாரும். அவர் ஏதோ சாப்பிட்டுட்டே வீடியோ பார்த்து
Unmute button. Hello, Chandra. Welcome.
Hello, madam.
Yeah. Hi, Kirani.
Good afternoon, madam.
Okay.
It's too much.
You come late, no? When the chief cook you always come late, no?
Madam, sorry, sir.
Good afternoon, madam. Namaste, madam. Dr. Sitharashmi, madam.
Krishna Kumar,
madam, அது எல்லாம் உங்க மாதிரி பெரியவங்க ஆசீர்வாதம் நல்லா இருக்கேன் madam. With your blessings, I am fine, madam.
சரி சரி இன்னைக்கு ஒண்ணு பிரசன்ட் பண்ணலையா? Usually you have
இல்ல madam, நான் இல்ல யாரும் ஸ்லாட் விட்டு எனக்கு தரேனா madam.
இல்ல 12 கேஸ் இருக்குப்பா. இதுக்கே ரொம்ப நாளி ஆகும்.
அதனால தான் அடுத்த தடவை செய்யறேன் சொல்லிட்டேன் madam.
Okay, listen to all of us today.
Yes, madam. Yes. Madam, உங்க மூஞ்சி காமிக்கிறதானே madam? மூஞ்சி மறைச்சிட்டு பேசுறீங்களே.
மூஞ்சில ஒண்ணே இல்லையேப்பா.
ஐயோ.
சரி, ஓகே, இப்போ நான் வீடியோ போடு.
மேடம், ரூம் சூப்பரா இருக்கு.
கான்ஃபரன்ஸ் ரூம்.
மேடம், ஃபேண்டாஸ்டிக்கா இருக்கு மேடம்.
இது கொஞ்சம் சின்னதா தான் தெரியும். அது தெரியுது பாரு. You can see my image only little bit.
பரவாயில்லை மேடம். உங்க எங்க டீச்சர் உங்களை பார்த்ததுக்கே மனசு ரொம்ப திருப்தியா இருக்கு மேடம்.
ஐயோ.
Sir, good afternoon, sir.
Good afternoon, madam.
என்ன மேடம்?
இல்ல மேடம், விஷ் பண்ண அவரை. நல்லா இருக்கு. Very very happy to see you, madam.
Okay. I am also happy to see you all.
அப்படியே இருக்கீங்களே மேடம், நீங்க சீக்கிரம் என்ன மேடம்?
அப்படியே வயசாயிடுமா எனக்கு? நீ அப்படியே தான் இருக்கேன். அதே குண்டா இருக்கேன்னு சொல்ற அவ்வளவுதான்.
exactly at 2, madam. We are starting exactly at 2, madam. Welcome, welcome.
இவங்க வரலையேம்மா. ரேலா people. அவங்க தானே first.
Relaji, one நிமிஷம், I'll just check up.
வரட்டும். Let them come. இது ஒரு தெரிய போச்சு. க்ளோஸ் பண்ணியா?
Madam, if somebody is not available,
Hello. Malarmati ma'am.
hello. Yes,
Hello.
ma.
Ma'am, we are
Yes,
audible.
yes.
Asma and Priya here.
Yeah.
Can we start, ma'am?
Yeah,
Or
yeah.
should we-
Just a minute. Just a minute,
Okay.
please. So it's exactly, we are starting on time, and a very good afternoon to you all. And this meeting has a distinction of this is a final meet of this 2022, and this is our 32nd city pathology meet. And so we can go on to our first presenter from RELA. Dr. Asma, are you ready?
Yes, ma'am. Ma'am, are you able to see the screen, ma'am?
Yeah. Your screen is visible. You can start, and you're audible.
Okay, ma'am. So good afternoon, everyone. So on this last city pathology meet for this year 2022, I'm presenting a case from hematology. So this was a child, a 7-year-old male child who presented with right axillary lymph node enlargement, no hepatosplenomegaly on PET CT. It was a single lymph node which showed uptake. And the initial complete blood count showed a leukocytosis of around 50,000 per cubic meter. CRP was elevated and biochemistry test revealed hypoalbuminemia. So this case was referred to RIMC from Kanchi Kamakoti Child Trust Hospital. So the initial evaluation, we had also received a lymph node biopsy for evaluation. So as we can see, the lymph node biopsy shows atypical lymphoid cells, atypical cells which are arranged in a nested pattern. So the first DD for me was not a lymphoma at the outset. So initially I had put only pan-CK, which actually came out negative and had only highlighted the reticulum cells, which can be seen as the internal control. And peripheral blood smear, which was initially a count of CBC showing 50,000 count, we requested for the sample at the same time because the case was a difficult one. So as we can see, there was leukocytosis, there are polymorphs, and these are some lymphocytes with cleaving, and there are again some lymphocytes, atypical lymphocytes with vacuolation. I was not very sure whether these small lymphoid cells are also abnormal or not because it was a pediatric age group patient. So we just did a screening T tube or a screening T tube and B tube. B tube was normal with normal B cells, which were very scarce and they were polyclonal. And this was the T tube. As we can see, the CD45 shows a expansion of tumor cells here, query atypical. So it was around 69%. And the T-tube next markers, the usual markers that we put CD3, CD4, 8, 7, and 56. You can see that the atypical cells were CD3 positive in a subset and negative in another subset. And there was another subset which was a part of the tumor, which is showing surface CD3 and 7 negativity. CD4 in this scale, the log scale 10 to the power 3 to 10 to the power 4, we can call it as a CD4 variable expression. And this CD3 7 negative subset, again, it was showing some CD4 expression. Here, when we come to CD8, CD8 was down-regulated. So the thing was whether is it a PTCL with an unusual morphology on the lymph node. So we proceeded further. So on the lymph node also, I would like to show you the CD4 and CD8. So this is a CD4 marker, which is again correlating with the flow finding where the CD4 was heterogeneous. It is not positive throughout, but atypical cells, majority of them have taken up the CD4 positivity. This is CD8. You can see the reactive T cells, 8 positive T cells are highlighted, predominantly negative. Coming to CD5, which was done on IHC, CD5 again variable positivity like that of CD4. This is the CD45 expression, which again correlates with the finding on flow cytometry. This is again repetition of the pan-CK from the panel, which was negative. This is the EMA, which was done again at the same time. So EMA is showing variable expression, cytoplasmic expression. And this is a CD20 stain, which is again negative from the IHC panel. So any guesses on this from the audience, if anybody could guess what could be this lymphoma? Because the morphology was very unusual. It was a difficult finding for us. We requested for CBC from Dr. Rabia. She immediately sent it because the counts were doubling almost every day. The child presented with a total count of 50,000. The next day it was 1 lakh. On the third day it was 1.5 lakhs. So I was suspecting a lymphoma spillover. So coming to the CD3 here, as you saw in the flow cytometry, CD3 expression is again variable. There are nest of CD3 positive T cells and some are negative also. So proceeded with ALK. So ALK, as we can see, it was throughout ALK strong positive. Coming to CD30 expression, CD30 expression was again strongly positive. And this was an additional marker, CD43, which was again positive in these tumor cells. So the diagnosis was concluded as an anaplastic large cell lymphoma. In addition, I would like to just that the morphology was very unusual. We did look for hallmark cells. Yes, we could retrospectively go back and call some of them as hallmark cells, but it was not right at the outside. I could say that they were hallmark cells. So this is another case of a young patient who had pancytopenia, and this marrow picture where you can see these large cells with vacuolations. This is just to re-emphasize the fact that ALCL can have peripheral blood spillover with those small cell morphology as well as these large cells which can have cytoplasmic vacuolations. So this was again the flow cytometry of this case, a bone marrow case. 45 bright, 4 is down-regulated. And you can see CD25 and CD30 homogeneous expression. Here again, surface CD3 is down-regulated. So just concluding this particular case, and the cytoplasmic NPM ALK positivity in this particular case. Again, this was a case of anaplastic large cell lymphoma with bone marrow involvement. So this is an article from Craig and Foon, which will tell you what are the DDs to be considered when we get peripheral blood spillover by these mature T cell lymphomas. It also has other lymphomas included like the B cell and the plasma cell leukemia, what panels to be put and what we can look for in the flow cytometry evaluation. So as this case highlighted, CD4 positive and 8 negative. So these are the DDs. Sézary syndrome, TPLL, adult T cell leukemia lymphoma, anaplastic large cell lymphoma, angioimmunoblastic T cell lymphoma, and the last category, which is the peripheral T cell lymphoma, which can have downregulation of CD5, CD7. And this particular entity, the anaplastic large cell lymphoma, often can show loss of many pan-T cell antigens, where you may just get strong uniform positivity for CD30 ALK1. And our case also had CD56 expression in the flow. So CD56 expression is also known in ALCL. It can also express aberrant myeloid markers such as 13, 15, and 33. Another point to be highlighted is the cytotoxic granule associated protein like the granzyme, the T cell intracellular antigen, TIAs, can also be highlighted positive in a case of anaplastic large cell lymphoma. So anaplastic large cell lymphoma, except in the small cell monomorphic variant, we will get ALK gene rearrangement. The other variants are also available. That's why we need to choose the FISH panel wisely. So just a few words about anaplastic large cell lymphoma. It was first recognized based on the morphology and the sinusoidal growth pattern and the antigenic phenotype, which is very classical, CD30 uniform and strong positivity. The molecular pathogenesis has led to the new diagnostic tools, which basically is the ALK gene rearrangement. There are other variants such as the small cell and the lymphohistiocytic variants. The small cell variant is the one which is notorious to go for peripheral blood spillover. So that is what we were retrospectively thinking, that this could be a small cell variant. But if you look at the histomorphology, the cells are not really small. But the peripheral and the peripheral blood morphology, as well as when you put everything together, yes, we can conclude as peripheral blood did show the small lymphocytes, which were all atypical in nature, with the phenotype which was confirmed by flow cytometry. Most Hodgkin-like and the highly pleomorphic CD30 positive lymphomas are excluded from this category. New diagnostic tools, that is your IHC, and our diagnostic acumen on routine HNE to identify hallmark cells will be helpful in aiding the diagnosis in such patients. So what we recognize as ALCL has clinical and prognostic significance, because these patients can be benefited by anti-CD30 targeted treatment. So usual involvement is of the lymph nodes. Cutaneous and extranodal involvement is also seen, most commonly children and young adults. Frequently the presence of systemic symptoms is there. It has an aggressive natural history but has good response to chemotherapy. So these are the other sites which can be involved in anaplastic large cell lymphoma: skin, soft tissue, bone marrow, lung, and liver. Again, the histological spectrum has been summarized here. So what we need to know, that it can show hallmark cells which are always present, sinusoidal pattern of infiltration, perivascular rosetting. The cellular density may vary from hypercellular to hypocellular. Hypocellular cases may mimic an inflammatory process. Again, we need to be careful here. So I would like to conclude the case here. Any questions, I'll be happy to answer.
So good afternoon, Dr. Asma. Dr. Chandra here.
Yes, ma'am.
It was a very exhaustive and very nice presentation of an anaplastic large cell lymphoma ALK positive. Small cell variant that also, which is very difficult to diagnose and which is a commonest with the leukemic type of presentation.
Yes, ma'am.
One query which I have in this particular case is you showed a picture with CD3 positivity, right? Usually anaplastic large cell lymphomas and especially the small cell variants are known to be CD3 positive only in 25% of the cases. No? Mostly it will
Yes,
be
ma'am.
negative.
CD3 is usually negative. Yes, ma'am. That's what I put in the theory part also. ALCLs are usually CD3 negative. But on flow only, ma'am, we could pick it up.
Yes. Okay.
The flow
Okay.
cytometry only could pick it up. In the histopathology part, the CD3 was predominantly, if you see, ma'am, it was negative.
Okay.
Here, ma'am. This is the CD3.
Yes.
So only this flow was done in addition only, ma'am. So here, that's why we could isolate that only a subset was CD3, and there was a half of the population was CD3 downregulated.
Okay. So in which case, peripheral T cell lymphoma, like how did you differentiate? Only because of ALK positivity, correct?
Yes, ma'am. On IHC, yes, ma'am. Very much.
Yes.
Because we had lymph node and we had the IHC workup, we could conclude it as a ALK positive anaplastic large cell lymphoma.
Yes. Yes.
Otherwise, it's a difficult call, ma'am. Otherwise, we'll have to think of PTCL as the DD.
Yes. Thank you.
Yes, ma'am. Ma'am, shall I give the slide to Dr. Lakshmi? Hello.
Valar, are you there? Yeah. Yes, I think so. Dr. Valarmati is there? Yeah, in which case, go on, no, Lakshmi?
Yes, ma'am. Okay, sure.
Good afternoon, all. I'm Dr. Lakshmi Priya from Dr. Ella Institute. So this is a 31-year-old male with a history of chronic kidney disease. In the year 2015, the patient underwent right renal transplantation and the patient was under immunosuppressive therapy. The CT scan, which was done outside, revealed a bladder mass on his routine follow-up, after which he was referred to our hospital. In the year 2022, his MRI revealed a mass in the left lateral wall of urinary bladder with perivesical fat invasion with an image staging of T3. The patient then underwent transurethral resection of bladder tumor followed by radical cystectomy. This is the gross image of the bladder specimen which we received. So here we could see an ulceroproliferative tumor in the left lateral wall of bladder with the red arrow indicating the perivesical fat invasion. Coming to the microscopic finding, this is a scanner view of the section. In the left, we could see the normal bladder. We could see the normal bladder urothelium, and in the right, we can see a cellular neoplasm infiltrating through the walls of the bladder with invasion into the perivesical fat. Here we can see the normal bladder urothelium with an infiltrating neoplasm. And here again, an infiltrating cellular neoplasm with a foci of necrosis, the insert showing dysplastic urothelium. The low bar showing diffuse sheets of tumor cells infiltrating into the perivesical fat. So in a higher part, we could appreciate the morphology of tumor cells. Here, the tumor cells are predominantly spindle-shaped, and they have moderate amount of eosinophilic cytoplasm with high nuclear cytoplasmic ratio, hyperchromatic nuclei. The tumor multinucleation is also identified. In this field, we can see a very brisk mitotic activity in the tumor. Here we can see around 10 to 12 mitosis per hyperfield. So, in a clinical setting of a renal transplant patient, and with this high-grade urothelial carcinoma, we strongly suspected a viral-mediated oncogenesis in this case and went ahead with the IHC. So this is GATA3. We can see the normal urothelium and also the tumor cells expressing tumor cells showing a strong nuclear positivity for GATA3 marker. This SV40 IHC. The normal urothelium is completely negative, and these are the tumor cells which are showing strong nuclear positivity for SV40 IHC. And here we can see the dysplastic urothelium, which is showing a strong nuclear positivity, and also the tumor cells, which are showing a strong nuclear positivity. So this, the SV40 expression here explains the expression of polyoma-specific T antigen in the tumor cells. And also the SV40 is expressed both in the dysplastic urothelium and also in the tumor cell population, depicting the dysplasia carcinoma sequence in this case. And this is P16 IHC. We can see the P16 IHC is completely absent in the normal urothelium. And here the tumor cells are showing block, strong nuclear and cytoplasmic positivity in the contiguous tumor cells. And here again, the dysplastic urothelium and also the tumor cell populations are strongly positive for P16. In this context, the P16 positivity is due to increased signal activation via the cell cycle RAS MAP kinase pathway. And as indicated by the literature studies, many of these tumors neither detected a viral HPV DNA nor P16 gene amplification. And this is P53 here, which is showing moderate to strong nuclear positivity. Here, usually the polyoma T cell antigen tags with the P53 gene and causes dysregulation to the gene, because of which there is an expression of P53 in these cells. Eberish IHC, it is negative in the tumor cells and also in the dysplastic epithelium. The insert showing the positive control of Reed-Steinberg cells in Hodgkin's lymphoma. So we gave the final diagnosis as invasive urothelial carcinoma, sarcomatoid variant, high grade, with a stage of PT3B, as we saw macroscopic perivesical fat invasion. So in view of SV40, P53, and P16 positivity, the possibility of polyoma virus-driven carcinogenesis was suggested. Few words about BK polyoma virus. Polyoma hominis, which is also known as BK polyoma virus, is a human-specific SV40 monkey-derived polyoma homologue. This tumor was introduced into the human population via contaminated polio vaccines that was obtained from a naturally infected not naturally infected monkeys. So this virus is associated with numerous pathologies like BKV, allograft nephropathy, hemorrhagic cystitis, urethral stenosis. Its etiological role in bladder cancer is most commonly elicited in patients following a solid organ transplantation. So pathogenesis, usually 90% of the human population are infected with this BK polyoma virus in the childhood itself. But when there is an immunosuppression, there is a BKV reactivation in the urinary tract, followed by P53 inactivation, pushing the cell cycle into the G2S phase initiation. And after a period of time, after some time interval, there is viral mutation and replication, leading to genomic instability, which on further hits leads to neoplasia. So an increased level of BKV viral load implicates its etiological role in cancer development. In our case also, the patient, the viral PCR of the patient showed increased copies of viral DNA above the threshold. The increasing recognition of high-grade BK polyoma virus mediated renourinary tumors in patients with a history of solid organ transplant requires heightened vigilance in this population for early detection and treatment. Given their long latent period, these tumors might pose a serious clinical problem in the future. Thank you.
Thank you, Dr. Lakshmi. That was a nice case. And
thank you, ma'am.
Is there any proportion of the percentage of the spindle cell component only then you call it criteria for calling it a sarcomatoid carcinoma?
It was predominantly, ma'am, more than 80%. Around 80% of the tumors was predominantly spindle cell, ma'am.
No, I just want to know what is the criteria. Like if a 90% mucinous, then you call it mucinous carcinoma of the breast.
In the WHO, they have just given the spindle cell. They didn't mention any cutoff for calling it, ma'am. We should also see a urothelial component
element. You should also see a admixed with a conventional urothelial element. But even if it is a 40%, 40%, yours is an 80% spindle cell component. But even if it is a 40% component, can it still be called sarcomatoid?
Yes, ma'am.
There are few literature reviews which say that more than 10% sarcomatoid element in a high-grade urothelial carcinoma should be called as sarcomatoid carcinoma, urothelial carcinoma.
Even if it's a 10%.
Yeah, more than 10%. Some of the literature reviews say. But others also do say that how much ever little it is, even if it is less than 10%, 1 or 2% of sarcomatoid elements being present in the urothelial carcinoma has to also be mentioned in your report, saying that I am seeing high-grade urothelial carcinoma along with such and such component. For example, say 4% or 5% of sarcomatoid elements also, which indicates that the patient is definitely going to have a poorer prognosis when compared to pure and simple high-grade urothelial carcinoma.
Okay.
Yeah, I think what Chandra says is correct. Actually, there is no specific mention of any percentage in the current 2022 WHO, but they do mention that if there is a component of spindle cells, which is quite atypical, and along with this thing, you have to mention it that there is a sarcomatoid component. Just like in your RCC, even 1% matters, because they may behave badly. That's how it is. Yeah. Very nice case, Dr. Lakshmi. Dr. Lakshmi, one question.
Yes,
so this did not have BK virus before. How could you? How do you say that this BK virus is the causative thing for causing this urothelial carcinoma? Has literature mentioned something like that?
Yes, ma'am.
It can induce urocarcinogenesis. Is that it?
Yes, ma'am. Yes, ma'am. It's very common.
Yeah, Chandra, actually, we also thought of a sarcomatoid urothelial carcinoma because of the history of post-transplantation on immunotherapy, if you search the literature, you get the answer. And
yes, ma'am.
So BK, polyoma virus is, well known in the literature. In fact, actually, Impana mentioned that. So,
yes, ma'am. Even in peripheral stem cell transplantation,
they don't have to be impregnated with the virus, I think so. And they have demonstrated with the markers that it is associated. They have only suggested the possibility of a, polyoma is has to be
Can
considered.
cause, can, because
But in
obviously the
this-
patient is already immunosuppressed. So
Yeah.
probably
Yeah,
that
and
is
then
the
in this particular patient, Lakshmi Priya did show, no, ma'am, the almost like a causal association with a comparison between the normal urothelium with the dysplasia
Yes,
and then the
dysplasia,
carcinoma.
yes.
The dysplastic areas and the carcinomatous areas are showing BK virus positivity. So I
Yeah.
think it should be causal. And the
Yeah.
literature also mentions the causal relationship between BK virus and the development of high-grade urothelial carcinoma.
Yeah.
This can happen post-transplant with solid organs or also after stem cell transplantation, ma'am, which is rarer. So solid organ transplantation producing a BK virus associated urothelial carcinoma is much more common when compared to stem cell transplantation related BK virus positive urothelial carcinoma is what the literature says.
Yeah. And here, as you said, they have demonstrated that in the dysplastic epithelium also.
Yeah.
So probably
Yes, ma'am.
it got infested, and over a period of time, what was the time gap between the transplant and development?
7 years, ma'am. 7 years, ma'am.
So that is obvious.
Actually,
Then it
wanted to
is a
ask,
viral carcinogenesis. Yeah, correct. Correct.
Yes.
That kind of accounts for it. Thank you. Very nice, Chris. Thank you.
How is the
Thank you,
patient
ma'am.
doing
Thank you.
now, Dr. Lakshmi? How is the patient doing now?
He's fine. He's doing okay, ma'am. He's doing fine only, ma'am. He's not from he's abroad, ma'am. So all we could get was his viral DNA was elevated after our report.
Okay, ma'am. Okay.
And urine findings, just out of interest, if at all you did demonstrate some decoy cells or something, they say, like, I don't know if you
We
did, but still.
Dr. Gauri here, ma'am. In this case, we did not receive any cytology sample, urine cytology sample as such.
Okay.
The patient landed here with diagnosis of bladder mass on his routine follow-up.
Voice is not very clear, Gauri Priya.
We did not receive any urine cytology sample, ma'am.
All right.
Patient came here just because he was diagnosed with a bladder mass during his routine follow-up ultrasound and CT elsewhere. He is from Bangladesh. From there only he was referred here, ma'am.
Yes. Thank you.
Okay. Thank you, ma'am.
Okay, Dr. Lakshmi, thank you. Thank you for this two wonderful cases from Rela Institute, and thank you, Mukul sir. And can we go on to the next case presentation by Mehta Hospital? Dr. Impana?
There were one more case by Gauri. What happened to that?
Gauri, are you presenting another case?
There were 3 cases quoted in your list.
No, madam. Dr. Gauri is not well. Dr. Gauri is not well, she told me. That's
okay. We will start our presentation.
Welcome, Dr. Impana. Your screen is visible and you can start.
Good afternoon, everyone, and welcome to the last City Path meet of the year. So I'll be presenting a case of 4-year-old male who presented with stridor. 4-day-old male who presented with stridor and had no other complaints. On antenatal history, the mother pregnancy was uneventful. On 2D echo, the baby had a aortic arch, abnormal branching pattern, and mild retrognathia was also there. Otherwise, the baby was normal. So at 13 days, we received a histopathology sample of 2 containers. So the first container was from the nasopharynx. We received a 1 × 1 centimeter whitish soft tissue. During peroperatively, they told they had a cheesy material and hair in the soft tissue. And said the container B was a very tiny whitish soft tissue measuring 0.5 × 0.5 centimeters. So this is the gross showing the cystic soft tissue filled with cheesy material and the hair. So on histopathology, we saw tissue lined by cystic lined by keratinizing stratified squamous epithelium with all the adnexal structures, hair follicles, and the lumen was filled with lamellated keratin debris. Also, adipocytes was there, and the myxoid mesenchymal stroma with congested blood vessels. Also, a focus of respiratory epithelium was seen, which is a endodermal derivative. So the second container showed only glial tissue. So it was all eosinophilic cells with eccentric nucleus and a pinkish cytoplasm in a loose stroma. So this was also showing the post-auricular mass, showing only the glial tissue. So when we went back to the clinician and asked for the investigations, they told at 4 days the baby had an X-ray done and it showed a minimal soft tissue prominence in the left auricular region. So it was followed by an ultrasound which showed a iso to hyperechoic lesion with well-defined margins in the post-auricular region. So a CT scan or MRI was advised. So on CT, they saw to the left image, we can see an elongated oval-shaped lesion which was extending from the eustachian tube into the nasopharynx. Also another lesion which was seen in the post-auricular region. So we had received 2 containers from the nasopharynx as well as from the post-auricular region. So correlating with the endoscopy findings, CT scan and the X-ray findings, we gave a diagnosis of a nasopharyngeal teratoma. So after 2 months, when the baby was 2 months and 20 days, again the baby developed progressive noisy breathing and stridor, for which the baby was evaluated. And LDH was found to be raised, 410, and alpha-fetoprotein was also raised. Again, endoscopy was done and the whitish mass with cheesy material and hair straps were seen. So we received again polypoidal whitish tissue measuring 1 into 1 centimeter. And this was the histopathology showing a polypoidal tissue lined by mature keratinizing stratified squamous epithelium with adnexal, with the hair follicles, mainly the hair follicles was there. And there was no glial tissue which was seen in the first time when we received the biopsy. So these are all the hair follicles surrounded by the inflammatory cells in the loose myxoid stroma. Again at 5 months and 8 days, so the like after 2 months the baby was discharged and it was uneventful. But again when the baby was 5 months and 8 days, the baby came back with the same complaints. But this time serum beta HCG was reduced and alpha-fetoprotein was also reduced compared to the previous values. And we received biopsy from the nasopharynx, which was a whitish nodular soft tissue 1 into 1 centimeter, and it was all embedded. And this also showed a polypoidal tissue with similar findings as the last time, with hair follicles as the only component of the region. So this time we concluded it as a nasopharyngeal dermoid with synonymous to hairy polyp, which the clinicians were thinking. So now the baby is 8 months old on regular follow-up and no recurrence has happened yet. So these hairy polyps are also called as dermoids or keratoid tumors, and they are the rare tumors of naso-oropharyngeal region with the incidence rate of 1:40,000. It usually presents at or shortly after birth, and there are various theories for its etiology. One being acquired traumatic implantation of the skin or mucous membrane within the deeper tissue, or due to a congenital inclusion of germ layers into the deeper tissue at points where the developing somatic region fails to completely fuse. Or it can also be due to implantation of pluripotent cells which grow in a disorganized manner. So this hairy polyp was described by Arnold way back in 1870. And he gave a classification of this hairy polyp as dermoid, which means there is bigerminal origin, meaning ectoderm or mesodermal origin only. Or it could be a true teratoma where all the 3 germ layers are differentiated into specific tissue, which we saw in the first biopsy. Or if it is poorly differentiated, it is called as a teratoid type of hairy polyp. Or another one is epignathy, which is a rare oral tumor, which is also called as fetus in fetu. So this is just a revision of the derivatives of ectoderm, endoderm, and mesoderm. So the first biopsy we had all derivatives from ectoderm, endoderm, and mesoderm. So as then when the time passed, so some people even consider it as a hamartoma, which is composed of tissue that is indigenous to the site, or else some people even try to call it as a corystoma, which means a foci of histologically normal tissue, which is not usually found in this location. So differential diagnosis of this is intranasal glioma, hemangioma, or neurofibromas, or lymphatic malformation, which can be identified well in the histology. So what is the importance of radiology in this cases? So it was to rule out any intracranial involvement which was absent in the in this patient. The cause for recurrence is not known in any of the cases which are described in the literature, but the cause is likely to be due to the difficulty of obtaining clear surgical margins due to this broad-based lesion as seen in this case. So these are the references. Thank you.
Actually, this case, day before yesterday, we had the neonatology, city neonatology meet, just like our city pathology meet, and the same case was also discussed by them and in a very much detailed clinical perspectives. I actually requested Dr. Lakshmi, our chief of neonatology unit, to add her inputs in this as a clinical perspective, but unfortunately she's held up in another meeting. And what was the outcome of that was the question of, why this child had so much of recurrency. The child was only a 4-day-old child when it came with the extreme stridor, and it was so painful to see the child suffering for air, but Lakshmi immediately phoned me up and asked me, and then when they sent the biopsy, they wanted to know what was the reason for that. And the moment the surgical intervention was done, the child was relieved of all the symptoms, and great relief to the parent as well as to the treating doctors. So they were very, very happy, but they were unhappy with our diagnosis of, because clinically they thought it was only a hairy polyp, which was reported in the literature. But when we told them it is a teratoma, they were a little skeptical about it. But then we had to explain to them, and because of the 3 which she had mentioned here, teratoma is the one which has a potential for recurrence. So immediately after a few months, the child had almost 3 surgeries, and the patients were also, a little bit upset because such a small child going for a repeated surgical intervention was not very palatable to them. But but they had a full confidence in our hospital and the treating doctors, and finally they were able to. I won't say it is a complete remission because the ENT surgeon who discussed the case yesterday, he said the recurrence is not because the tumor has recurred, but because we were unable to remove it in total because of the difficulty in doing the surgery in a 4-day-old, 10-day-old child and all that. So this being a very, very rare case of nasopharyngeal teratoma, we thought we'll definitely present it in the forum. I would like to know whether any of the pediatric persons here, whether they have come across such kind of patients with a stridor and a nasopharyngeal mass.
Madam, we have reported one nasopharyngeal teratoma long back. But as you said, though it is a benign one, because of the location, it can keep recurring because complete removal is very difficult in such cases. Absolutely. That's it. That is true.
Okay.
Ma'am,
all elements were mature, madam. All elements were mature. There were no immature elements.
Yeah, no, ma'am, no immature elements.
Ma'am, was there any congenital anomalies, ma'am? Was there anything?
Mild retrograptia and that which I told you, ma'am, in 2D echo, there was an abnormal branching pattern of the carotid artery. Usually, teratomas are said to be associated with these congenital abnormalities, ma'am.
This baby had none, na?
Yes, ma'am. Like it was just a mild branching abnormality and mild retrogranthia. That's all.
Okay. How is the baby now?
That is what, ma'am. Now is recurrence free, but the clinicians are expecting the recurrence because they feel still it is not. They are not able to completely remove the teratoma part.
Okay.
Antenatally, was any suspicion there?
No, ma'am. No, ma'am. Usually they say, literature says polyhydramnios if the mother has, with the fetal ultrasound showing any this thing, they have to suspect. But this baby did not have any findings antenatally.
So ultrasound imaging was normal. Antenatally was found.
Yes.
No suspicion.
No suspicion.
Because AFP levels and all that, no, these are indications.
At birth, so they told baby had distress, ma'am. Respiratory distress was there at birth, but it was managed.
Yeah, meaning correct. Meaning the like lesion must have been there in utero.
But that's what when I asked the clinician specifically, they told it was not detected antenatally.
Yeah, probably they did not make the diagnosis antenatally. Imaging and AFP levels, no, serum AFP also usually is elevated in a teratoma, so probably they missed on.
Thank you, Dr. Limpana.
Yeah.
Yes.
Madam, are you sharing another case, madam?
Yeah. Lydia is waiting here. That is a very,
Okay,
very
ma'am.
simple case for everybody, but very
Okay, ma'am.
interesting finding.
Yes, ma'am. Please do.
Yeah.
Ma'am, your voice is not very audible, ma'am. Bunch of people are saying, ma'am.
My voice.
Come on, ma'am.
I'm sitting far. That is why.
Good afternoon. So this was an incidental finding we saw in our regular reporting. This was a 34-year-old female who presented with abnormal uterine bleeding for 6 months, and an endometrial biopsy was done. So it basically showed a disorderly proliferative endometrium with early secretory changes.
Dr. Impana, a minute, please. Your screen, it is just in the previous case. Are you do you have a PowerPoint? Are you sharing the new case? Please do.
Now,
no, it just stands there on the with your last slide.
yes, stop. Now can you see now?
Yeah, we are. Yeah, thank you. It is. Yeah, you can start. You can start from your case history. Yeah.
You're not able to say?
Yeah, Dr. Impana, you can start. The screen is visible. Yeah.
Lydia is presenting.
Yeah. Is it visible, ma'am?
Yes,
Hello?
yes, please go on.
Yeah, it's visible. Please go on.
Okay.
Is it visible?
Yes, ma'am. Yes, ma'am. Very clear and visible. You can go on, ma'am.
Yes, ma'am. So this showed a disorderly proliferative endometrium with early secretory change. The striking feature in this biopsy was these eggs which we were able to notice. It was present throughout the slides, like normal. We took deeper sections as well as within the endometrium also. We were able to identify these structures. So we suspected egg. So we looked into certain literature and images, and we thought it could be the egg of Entropius vermicularis. So with that, we gave a diagnosis of disorderly proliferative endometrium with eggs suggestive of Entropius vermicularis. So this Entropius vermicularis is usually an intestinal nematode. So the extra-intestinal manifestations or its presence is usually a very rare incidental finding, and there are very few cases in literature as well. And it, usually this Entropius extra-intestinal manifestation, the most common location is female genital tract. So there are case reports where we can see this Entropius eggs in the endometrium, even up to ovaries. There are cases which has been reported. So this ectopic location is uncommon, so we thought we will just put it as a spotter. So the differentials for this egg of Entropius could be, the closest would be the cystosoma or entamoeba. But usually this Entropius eggs are plano-convex in shape, and they are surrounded by a thin hyaline shell. Whereas the hematobium, the classical finding would be the small terminal spine which we can see. And of course, amoebic trophocytes, we all know we can do a PAS stain as well to pick it up. So there are few literatures which shows Entropius in endometrium, in ovary. So always know, even in routine reporting, it's important we notice if any parasite is there. Also, all these ectopic locations we'll also have to consider when we are reporting, even in routine reporting. So we just wanted to highlight this finding.
Yeah, it's only a spotter, and I discussed it with the gynecologist, and they were all quite surprised to hear this because none of them have seen. I don't know whether any of you have reported an Entropius in endometrial curetings, though it is reported in the literature. And as she said, one of the commonest extra-intestinal location is the female genital tract. Because of the anatomical location and the vicinity of the anal region, they can travel through the vagina into the uterus, and even up to the tube, up to the ovary also it can travel. That's what the two articles which you have quoted says. So I don't think there is any ambiguity as far as the diagnosis was concerned. And of course, we told the clinician to look into the anal swab to find out whether there is any pinworm in that, and also necessarily treat the patient. But unfortunately, the patient never came for follow-up, it seems. So that was the sad part of the story. But I thought, at least the awareness should be created to scrutinize the endometrium properly, so that in case you find anything odd like this, it has to be definitely reported. That was the only reason. And also I thought, Kanchana is there. Kanchana, has she come? The longest runner of the gynec pathology. And so I thought, any of you, if you have seen, then at least you can share your findings with us. That was the idea behind presenting this case. You're just a spotter.
Ma'am, I forgot to note the age of the patient, madam.
34 years now.
34 years.
Yeah.
Okay. She presented with DUB.
Yeah.
Nice.
Dr. Impana, what was the clinical?
AUB, abnormal infant baby.
Okay.
Then you have to wait for me.
So that was, we wait for any discussion.
There's nothing to discuss, madam.
It's very interesting.
Yeah.
Interesting.
Awareness creation.
The reason was it was an interesting finding, so we thought we will put it up so that everybody will be at least aware of this, nothing else.
Yes, ma'am. Yes. So next time we see something like this, we can always make a diagnosis and put it up in the forum aspect.
Yeah. Thank you, madam, for the two wonderful cases. And thank you, Dr. Impana.
Lydia, you always forget Lydia. Lydia is the other person who presented the case.
Okay, ma'am. Thank you, Dr. Lydia. Thank you, Dr. Impana.
Thank you.
Okay, and the next case presentation will be by Neot Hospital's Dr. Anandi.
Yes, ma'am. Can you see the screen?
Yeah, your screen is visible and you're audible. You can start.
Good afternoon, everybody. Moving on to clinical history. It's a 3-year-old boy child. He is a known case of lipomyelomeniingocele, operated at 2 months of age. Now he came with complaints of stiffness in lower limbs and foot deformity. MRI showed an intradural lipoma. There's another incidental lesion in the left suprarenal region. That mass was measuring 3.7 by 3.3 centimeter. Initially, that intradural lipoma was excised and it was reported as lipoma only. Then they did all the urinary and serum markers, hormone levels where everything was normal. So they put query adrenal mass and laparoscopic excision of the lesion was done. So this lesion, they clinically they thought of adrenal myelolipoma. Can you hear me, ma'am? My screen is not moving to the.
Okay. Yeah, you're audible and it's moving. Okay. You're seeing the gross picture.
So the gross image was showing predominantly a yellowish mass, which was solid and firm, and some focal grayish areas were there. So we thought of a lipomatous tumor, and in low power, it was showing predominantly adipocytes with some eosinophilic areas, which on high power showed smooth muscle. Like in this image, you can see that there are smooth muscle nerve fibers, blood vessels, and some tubule-like structures. And in some other foci, we also found some cartilage, glial tissue, and some cysts, very tiny cysts lined by stratified squamous epithelium. In few foci, there were also like these primitive glomeruloid structures were present, and few tubules were also seen. And in the periphery of the tumor, we found like primitive blastemal and epithelial elements as well. There were these cells showed like very high NC ratio, and mitotic activity was also noted in some areas. And few areas showed like vague rosette-like structures showing primitive tubule-like structures. No anaplasia was seen. So at this point, we noted that the tumor had ectodermal and mesodermal derivatives, along with some tissue which suggestive of nephroblastoma, like blastemal epithelial components were also seen. So we did few IHC markers, WT1 was positive in the blastemal area, which we thought of, and epithelial area was also, few tubule-like structures were also taking up, and Paxite was strongly positive in all these areas. PAN-CK was negative in the blastemal area, and it was highlighting these cysts and tubules. Few GFAP showed the highlighted the glial tissue, and SMA highlighted the smooth muscle components. So with this, we weren't able to come into proper diagnosis. So we did an extensive literature search for this, because we were able to see some tumor component of teratoma, which we thought like teratoma component, ectoderm and mesodermal derivatives, and some nephroblastic tissue was also there. So how to call this tumor, whether it's a teratoma with a nephroblastoma, or whether it is nephroblastoma with heterologous elements. The important point to note was it was not in the renal. The patient kidney was normal. So it was in the suprarenal in retroperitoneal area. This lesion was there, and it was a small lesion only. So morphology and IHC cannot differentiate between these two names terminologies. Based on the tumor morphology, it had very less nephroblastoma elements, like only 20% was seen in the overall tumor. So we called it as an extrarenal teratoma with nephroblastoma in retroperitoneum. So moving on to discussion, this terminology, another Variant et al. Was the first person to use teratoid Wilms tumor. He described this Wilms tumor if it is having more than 50% of teratoid elements. He called these such tumors as teratoid Wilms tumor. We searched and review of extensive literature review. We saw that such cases were also reported, extrarenal teratoma with nephroblastoma in retroperitoneum. This exactly the name we have given. It was reported in a journal named Medicine in 2017. This journal also included a review of literature of all such cases. So they had done extensive search in all the PubMed, and they had termed it like teratoid Wilms tumor, teratoma with nephroblastic tissue, and teratoma with nephroblastoma. So with all these terms, they had searched and found only 53 such cases were reported in addition to their case. The pathogenesis of this tumor is still unknown, and its origin is also controversial. Some authors say that they are actually from teratoma only, giving rise to some nephroblastic element. So they are predominantly considered as germ cell tumor. But the presence of nephroblastoma-like tissue outside the kidney suggests that it may be a hybrid of two different neoplasms that originate from pluripotent stem cells. So in their case report, they found that all the cases were predominantly young children except 2 cases. And it was the mean age of diagnosis was 6.5 years, with male to female ratio was 1.3:1. And abdominal pain and distension were the most common presenting symptoms. The location of the tumor, commonly they found like kidney was the most common site. Even among the 54, 31 was kidney, and only few cases were extrarenal. So the other common sites like retroperitoneum, sacrococcyx, testis, and mediastinum were also reported. So in microscopy, in majority of the cases, in all the 54 cases, the predominant component was found to be adipose tissue. This was strikingly similar to our case, because we also had like almost 60% of the tumor was composed of only adipose tissue. And the next most common component they found was epithelial tissue. And the tumors were also showing other heterogeneous tissues like skeletal muscles, smooth muscles, cartilage, immature glomeruloid elements, and tubular structures. In general, when we come to prognosis, they had a better prognosis than conventional Wilms tumor. But for any Wilms tumor, they used to give preoperative radiotherapy or chemotherapy. But this tumor, they did not respond to such preoperative radio or chemotherapy. The treatment of choice was complete excision. The diagnosis of this tumor, preoperative diagnosis, is very difficult based on imaging alone. Because of the variable presentation, lack of awareness, there is no standardized diagnostic criteria as of now. And excision biopsy is the only option for establishing definitive diagnosis. and no molecular studies available as of now to prove this tumor. So the differential diagnosis for intrarenal tumors to be considered at that age can be nephrogenic risk, cystic partially differentiated nephroblastoma, mesoblastic nephroma, metanephric adenoma, and other small round blue cell tumors like neuroblastoma or Ewing sarcoma. So ours was totally extrarenal tumor, and so we couldn't fit in any of these tumors. So even though we were reading about all these tumors to find any category, this was not at all fitting because there was no cystic component at all, first of all. And finally, the take home points. This is a very rare entity. I mainly present this case so that if any of them is aware of such case, because first time we are seeing this type of case. Clinical features are also variable and they are very non-specific. There is no standard diagnostic criteria or terminology is established so far. So imaging modalities cannot accurately differentiate these tumors from other tumors. Morphology is the gold standard, and the treatment of choice is complete excision only. Thank you. Mainly I presented this tumor so that we were surprised to see such a combination of two different neoplasms in one tumor. So I would like to have any other opinion on this case or any questions. Ma'am, any questions, ma'am? Any
Yeah,
other?
that was a nice case, Dr. Anandi. It was a rare one. We'll
Yes, ma'am.
Nicely elucidated. Like if it is extrarenal, what are the differentials, and if it is intrarenal, what else are we supposed to think of, and all those. But how did you consider the possibility of a nephroblastoma IHC because of IHC, or just by morphology you had a suspicion?
No, ma'am. Morphology itself, first we had a suspicion because nice glomeruloid structures were seen. Like this, it was seen in many areas. The abortive glomeruli, which we classically describe in nephroblastoma, and some tubular structures were also seen. And then in the periphery, there were like initially we thought what we thought to be like immature neuroepithelium because of rosette like appearance. So we did IHC. We had suspicion based on the glomerular part mainly. So we did IHC and it turned out to be WT1 and Pax8 positive.
Yes. That's very nice.
Thank you, ma'am.
What is the behavior of this tumor?
Ma'am?
What is the behavior?
It is generally said to have a good prognosis with complete excision. Compared to Wilms tumor, they are telling the prognosis is better. But the unusual thing is, usually Wilms tumor responds very well, better in chemotherapy and radiotherapy, which they give pre-operatively. This tumor is not responding to chemotherapy or radiotherapy. Only surgery is mainstay of treatment.
Post surgery, there is no need for
post surgery. They no need for much of chemotherapy or radiotherapy. It's not responding. Also, they just have to follow up. That's what the literature says.
Okay, that was a very good case. Thank you.
Thank you.
Thank you, Dr. Anandi. Can we go on to the next presenter? Welcome, ma'am, Ariel Viri, ma'am. And from Apollo Cancer Center, first case by Dr. Sweta.
Good afternoon, ma'am. Is my screen visible, ma'am?
Yeah, your screen is visible. You can start.
Good afternoon, everybody. This is actually a case where we had a diagnostic difficulty. So that is the main reason to present this. So it's an enigmatic case of metastatic lymph node. It was a 23-year-old gentleman presented to us in June 2022 with a swelling in the right side of the neck and difficulty in swallowing. So this was a painless swelling which was slowly increasing in size. Systemic examination was normal. Vital.
Excuse me, Dr. Sweta, your screen is not moving. We are not able to see your slides. It's only, yeah. You can go to the second slide. It would be good if you start presenting from the clinical history.
Now, ma'am, now is it okay?
No, we are just able to see the first slide.
Okay, I'll just log out and log in.
No. Okay, Sweta. Okay.
Ma'am, is it visible now?
Yeah, your screen is not visible, Dr. Swet, and your PowerPoint doesn't come up.
Now is it okay, ma'am?
Yeah, Sweta. Yeah, doctor. Yeah, you can start from the history.
Yeah. So this is an enigmatic case of metastatic lymph node. This was a 23-year-old gentleman who presented to us in June 2022 with a swelling in the right side of the neck and difficulty in swallowing. So it was a painless swelling which was gradually increasing in size. The patient did not have any other comorbidities and vitals were within normal limits. So because of the presence of the swelling, FNAC was done. It was reported as poorly differentiated malignant neoplasm. Since it was malignancy, there was an extensive imaging study in May. So MRI and PET-CT scan showed a soft tissue mass in the pyriform fossa. Ma'am, is the screen moving, ma'am?
No, your screen is not moving. Yeah. You can continue.
Now is it okay, ma'am?
Yeah, yes, it's okay.
Okay. So FNAC showed a poorly differentiated malignant neoplasm elsewhere, and MRI showed a soft tissue mass lesion in the right pyriform fossa, which was extending beyond the anterior midline to the left side, and there were multiple significantly enlarged lymph nodes on both sides of the neck. So when the PET-CT scan was done, it confirmed the same thing, and in addition, it detected multiple lytic skeletal metastasis. So for further workup, right supraclavicular lymph node excision biopsy was performed and sent for frozen section, where we had a difficulty in pinpointing the ontology. So we called it as poorly differentiated malignant tumor. So these are the sections from the lymph node where a normal lymph node tissue is completely replaced by the tumor, where it's a very cellular tumor. Some kind of aggregating and clustering is noted in the area which is depicted by the arrow. So in the similarly, the other areas also showed some kind of clustering. There were some areas where it was had a sheeted, very sheeted morphology, and the cells were small to intermediate size with prominent nucleoli and very busy tumor, very cellular appearing with mitotic activity. And there are some areas like this which showed like apoptotic debris. So meaning to say that it is a high-grade tumor with increased apoptosis. Areas there was some kind of clustering. So we were really not or a carcinoma or any other tumor. And in some areas there was this kind of morphology where it had like a pseudo-alveolar pattern or somewhat like a clefted pattern. So since we were not really sure, we gave a differentials of lymphoma, metastatic carcinoma, or a metastatic epithelioid sarcoma, or less likely melanoma, and suggested immunohistochemistry. So when the immunohistochemistry was done, to our surprise, we found very patchy positivity with CK, and LCA was completely negative. So whether are we dealing with any carcinoma which is showing patchy CK expression? So when CK7 and CK20 was done, both were negative. And Ki67 proliferation index was high, around 75 to 80%. So since CK was very patchy, we wanted to rule out whether it was epithelioid morphology of any other tumors. So we did with an extensive panel of IHC where vascular markers CD34 and 31 were negative, excluding vascular tumor. To our surprise, all the squamous markers P40, P63 and CK high molecular weight, all three were completely negative. And neuroendocrine markers, synaptophysin, chromogranin, CD56, again all three were negative. So we extended the panel and did markers for muscle differentiation, that is Desmin and MyoD1, again both were negative. And NKX 2.2, whether it could be any atypical Ewing sarcoma, we did NKX 2.2, again that was negative. Then D240 again was negative. So since young patient, we wanted to rule out whether it's a germ cell tumor, so PLAP was negative. To rule out any blastomemal tumors, TDT we did, that was also negative. So since it was a head and neck tumor with a neck mass, so we wanted to rule out a rhabdoid tumor. INI was done, so INIs retained positivity. And S100 showed very few focal cells, which was positive. So we were really not sure what is a tumor in spite of doing the extensive panel. So we are wondering what it is. Then again, when we went back to the slides, we saw the areas where it was very, very poorly differentiated and a high grade tumor, and patient had a pyriform fossa mass. So then came the nutcracker moment when we put up nut marker. It showed diffuse positivity. And as it is described, there is diffuse nuclear speckled chromatin positivity. So finally, it turned out to be a nut carcinoma. And since this being a metastatic site, we advised biopsy from the main lesion. And since being uncommon tumor, we suggested molecular studies. So a few points about the nut carcinoma. NUT stands for NUT, nuclear protein in the testis. It was formerly called nut midline carcinoma, but the term midline has been dropped because it was found that it can occur anywhere apart from midline locations. So it can affect people of all age groups. There is no sex predilection or geographic predilection. No clear risk factors have been identified. Most common sites of metastasis, it can involve any organ in the body. It is a high degree of malignancy with a poor prognosis of less than 1 year. It is an aggressive carcinoma defined by translocations involving the NUT gene and frequent squamous differentiation, that is abrupt keratinization, has been described. It is caused by translocations involving the NUT gene located on 15q chromosome. There are three fusion partners which have been described. BRD4 NUT, which is very most common, involving 67% of cases. The other translocations have been identified as BRD3 NUT and NSD3 NUT. There is no relation between HPV and EBV in these tumors. NUT immunohistochemistry is very sensitive and specific for the diagnosis. So being aggressive tumors, radiotherapy and therapy have been tried with a dismal prognosis. So when we did the literature search, we found few case reports and studies where this was an article where they studied 119 cases. So in that, the overall survival was very poor, with a maximum survival of just 26 months. Nut carcinomas have abrupt squamous keratinization, but in our case, it was lacking. So when we did the literature search, we found that few case reports had similar morphology. That is, there is lacking squamous differentiation. However, NUT immunohistochemistry was positive. So we thought that ours was like a similar case. So whenever there is a poorly differentiated tumor, especially in the head and neck location, the differential diagnosis which should be considered are basaloid squamous cell carcinoma, which shows keratinization and positive immunostaining with squamous markers and negative staining for NUT1 protein. Sinonasal undifferentiated carcinoma, as the name suggests, it is negative for all the IHC markers. High-grade neuroendocrine carcinoma, it has stipple chromatin and positive for neuroendocrine tumors, and NUT and squamous markers are negative. SMARC B1 deficient sinonasal carcinoma, this is one tumor which has been recently described, and few cases are increasingly being reported, which shows characteristic loss of INI1. Like in our tumor, we thought that this could be a differential, but INI was completely retained and NUT was positive. So hence excluding this SMARC-B1 deficient sinonasal carcinoma. And always lymphoma and melanoma should be a differential if it has a poorly differentiated morphology. So this patient was started with chemotherapy with paclitaxel and carboplatin, and 3 cycles of chemotherapy was given. Initially, he tolerated well and he was discharged. Later, when they tried to do biopsy from the pyriform fossa, he developed airway obstruction, so emergency tracheostomy was performed. So they decided to stop chemotherapy and started with radiotherapy for both primary disease and the bony metastasis. He was doing well, but 4 weeks later, he was admitted again for weakness of both lower limbs. And at that point of time in August, when MRI was taken, he showed progression in size and the number of metastatic lesions. So when he presented to us, it was June. So within a span of 2 to 3 months, there's a rapid progress and increasing in both the number and size of the metastatic lesions, and he was not responding properly. Then apart from the increase in the size and metastasis, he developed wedge compression and spinal cord compression. Because of the extensive disease, decompression was deferred. And since there was no improvement, we had informed the family about that, but they preferred to continue with chemotherapy. So as an alternative, PDL1 was just to try PDL1 inhibitors. We had done PDL1 IHC. It was 4 to 5% positive. So just as he was not responding with any line of treatment, so immunotherapy with pembrolizumab and conventional chemotherapy was continued. But unfortunately, in September, he developed cardiac arrest and succumbed to the illness. So in spite of all this, what is the future for such tumors? It is necessary to further explore the pathogenesis and molecular genetic mechanism of the disease to improve the treatment and prognosis of the patient. So being a difficult tumor, I thought to discuss both the differential diagnosis and to stress upon the point that NUT immunohistochemistry is a marker where if any other tumors with a high grade morphology and negative for all kinds of immunostaining, NUT is one marker where if the patient has a lesion which is rapidly progressing, high grade morphology, not fitting into any of the routine tumors which we see. So this IHC has to be tried. So NUT carcinoma is a rare neoplasm that should be clinically suspected with aggressive masses. IHC is required for accurate diagnosis. Chemotherapy and radiation are the mainstay of treatment as surgical resection is very much limited. Thank you so much.
Thank you, Dr. Shweta. I just have a clarification. You mentioned in the differential diagnosis, SMARC-B1 deficient sinonasal carcinoma. Was it positive for NUT or was it negative?
INI was retained, ma'am. So INI was completely retained.
I'm asking about that NUT1 positivity in SMARC-B deficient sinonasal carcinoma. Was
in those tumors, NUT1 is negative, ma'am.
NUT1, but
yeah, Dr. Shweta is right.
NUT1 should be negative, and there should be loss of INI1 in these tumors.
Okay. So it was negative. Okay.
Yes, ma'am.
And Dr. Shweta, one more question. In the course setting, for example, we do not have NUT1 immunohistochemistry. And at least I agree with you that it is the foolproof mechanism by which you can prove this type of malignancy. But can this abrupt squamous differentiation in a high-grade carcinoma be taken as a surrogate to suspect that it could be an NUT1 positive tumor?
Yes, ma'am. Being a young patient, highly proliferative tumors, if there is a midline, it's not very important that midline tumor should be there. But if it is midline, young patient, rapidly progressive tumor, not fitting into any of the morphologies, if there is abrupt keratinization, then this is one tumor which has to be taken into consideration, ma'am.
Yeah, Dr. Shweta.
Yeah, ma'am.
This abrupt keratinization foci, I was not able to, identify, we were thinking all other DDs except for this nut. Actually, it's an eye-opening case for undifferentiated carcinoma with the differentiation of keratinization. We have to think this entity. Very well brought out and nice presentation. And very clearly you have excluded one by one what all coming into our mind as a differential diagnosis. Very nice. Very
Thank
nice.
you so much, ma'am.
Thank you, Dr. Shweta. Thank you for that rare presentation. Can we go on to the next presenter, Dr. Ashwin?
Am I audible?
You're audible, Dr. Ashwin. You can continue.
Yeah. So hi, good afternoon, everyone. I'm here to present a splenic mass of a teenager. Going on with the clinical summary, the girl was a 17-year-old presenting with abdominal pain, on and off fever, and constipation and weight loss. And she was a known case of tuberculosis and was on treatment for it. And PET CT. Am I audible? So the PET CT was done for the case, and it was suggestive of a splenic abscess. And radiology preoperatively showed a bulky spleen measuring 12 centimeter in greatest dimension with an well encapsulated lesion measuring 7.8 cross 7.2 centimeter. MRI, it was showing an iso to hypointense lesion, whereas in T2 weighted image, it was mildly hyperintense with hypointense bands radiating from center in a cycle spoke pattern. So we received a splenectomy specimen in which the gross showed a well demarcated lesion in which a characteristic shiny to trabeculated fibrous area was seen, in which embedded are these reddish nodules heterogeneously distributed predominantly towards the periphery. And the lesion was measuring 8 cross 8 cross 6.5 centimeter. So this was one complete cross section of a splenic parenchyma with the lesion. So going on to the histopathology, the interface between the normal parenchyma, it showed a well demarcation with the lesion. It was unencapsulated. And lesion per se had this pale pink area comprising of the fibrosclerotic stroma, in which this irregular shaped angiomatoid nodules were all seen embedded. And this angiomatoid nodules, again, this is one more picture at low power. And this is a hyper picture of an angiomatoid nodule comprising of slit-like irregular vascular channels anastomosing with one another and forming a network of a vascular channel supported by fibrotic stroma. And towards the periphery, there were these rounded, well-defined vascular lumens supported by this basal lamina, and again supported by the fibrotic stroma. And this is the stroma that is intersecting between the angiomatoid nodules, which is very well established collagen deposition and appears very sclerotic and in areas had hyalinization too. So with the provisional diagnosis of sclerosing angiomatoid nodular transformation of spleen, we went ahead with the IHC, in which the first CD31 was able to highlight the entirety of the angiomatoid nodules. Most of the cells as in the angiomatoid nodule showed immunoreactivity to CD31. Thereby, this vast network of positive channels are all highlighted in CD31, which can be seen in the inset 2. With CD34 stains, only well-defined capillary structures seen in the inset were all appreciated. And this is a CD8 stain where scattered inflammatory cells within the angiomatoid nodule and sinusoidal type vessels were showing positivity. CD68 had this, it didn't stain per se any of the vascular channels, but had this non-specific kind of staining, and few fibroblasts and macrophages were all taking up the stain. So the final report was signed as it's consistent with sclerosing angiomatoid nodular transformation of the spleen. And this entity was first described in 2004 by one Rosai, Martel et al. So a quick discussion about this entity. This one is a non-neoplastic reactive vascular lesion, probably arising from an exaggerated stromal response to the red pulp of spleen. And earlier to the description by one Rosai, this was signed out as cord capillary hemangioma, and this terminology was given by Krishnan et al. And it is often considered as a sclerotic counterpart of splenic hamartoma. So gross wise, it appears solitary, well circumscribed, round to bosulated mass, and ranges from 3 to 17 centimeter, usually common in young female patients. Median age is 35 years. And as discussed, this histologically represented by angiomatoid nodules embedded in fibrosclerotic stroma. And angiomatoid nodules consist of this irregular vascular spaces, either open or collapse, depending upon the erythrocytes present within the lumen. And the internodular stroma shows dense fibrotic to fibromyxoid, with or without hyalinization, with or without calcification. And there are chronic inflammatory cells seen distributed, infiltrating the stroma. Sometimes it can be plasma cell rich too, and they may show significant IgG4 IgG ratio. And the relation is unknown, and whether to classify SANT as an IgG4 related disease, it's still not known. So the main point here is to demonstrate the three distinct type of vessels seen. First is the well-formed cord capillaries, which show immunophenotyping, immunohistochemically, it is CD34 and 31 positive. And second type of vessels is splenic sinusoids, wherein it shows positivity for CD31 and CD8. And small veins in a very intricate mesh-like pattern show only 31 positivity, and it is negative for 34 and CD8. So this tabular column depicts the staining process in most of the benign vascular neoplasm of spleen. Here, if you notice, the splenic hamartoma pretty much correlates with the IHC profile of sclerosing angiomatoid nodular transformation of spleen. The rest all can be easily delineated with the use of 31, 34, and 8. And electron microscopy wise, the endothelial cells pretty much looks like those that line the lymphatic vessels with the lack of Weber palette bodies and presence of pinocytic vesicles. And in veins that are seen in the periphery, they show pericytic, they are surrounded by basal lamina with presence of cytoplasmic filaments is noted. So in the workup of this case, the differential diagnosis to be considered are other vascular lesions of spleen with two major types of hemangioma and littoral cell angioma. In both these entities, it is rather a single type of blood vessels than the multiplets of multiple types of vessels. And the distinctive architecture that the SANT is gifted with is the prime thing to delineate the SANT from hemangioma and littoral cell angioma. And as discussed earlier, hemangioma will be 31 and 34 positive, whereas CD8 it is negative. And in littoral cell angioma, it is CD31 positive, whereas it is negative for 34 and 8 negative, which is quite away from its normal putative counterpart, which shows CD8 positive also. And hamartoma, which is a closed DD for the SANT, it is only classified based upon the architectural distortion and the presence of angiomatoid nodular pattern. And few literature say the delineation of hamartoma from a SANT is pretty much, it is well defined in SANT rather than hamartoma. It just merges with the splenic parenchyma, though they say it is circumscribed. And hemangioendothelium and angiosarcoma, with the help of like mitosis, proliferative indels, and atypia, and the pattern per se, like, it can be easily differentiated. And like in the lymph node where vascular transformation of sinuses happen, even in spleen, when red pulp is subjected to a chronic process, it can give rise to a nodular transformation of splenic red pulp, like in the case of a metastatic carcinoma due to exaggerated desmoplastic response from the parenchyma, sarcoidosis, or like in a case of an organized hematoma, or like in case of inflammatory pseudotumor, like follicular dendritic cell sarcoma. So this can show nodular transformation of red pulp. So in summary, the main identifying attributes are its solitary nature and circumscription, unencapsulation, multinodular angiomatoid appearance, and peculiar heterogeneous immunostaining profile for vascular markers. And in the first paper that Martel et al. Described this entity, it was that it happened to have a high prevalence, that is 20%, with a synchronous or a metachronous malignant tumors and lesions, for example, like abdominal disseminated calcifying fibrous tumor. And they attribute these things because this finding is an incidental finding. When they get evaluated radiologically for other metachronous, malignant tumors, which is happening separately, they get identified with this lesion. So the lesion is entirely benign, and splenectomy, even partial splenectomy, has been proven curative in so far. These are my references, and thanks for the opportunity. Any questions?
Wonderful presentation, Dr. Ashwin. One thing I just wanted to brought out here, the gross appearance of this lesion is very characteristic. The nodular presentation, like a whitish area alternating with the red things, very characteristic. And literally you have a hemorrhagic globular configuration. So by gross itself, I think if we have these entities in mind, we can delineate the conditions. And inflammatory pseudotumor also forms a part of it, isn't it?
Yes, ma'am. That can.
More of vascular tumor we form the DD, and the inflammatory pseudotumor also. Yes. Anyway, nice entity. Though it is incidental, it's very nice to see the gross picture and your description and your explanation and your marker presentation. Thank you, Doctor.
Thank you so much.
Thank you, Dr. Ashwin. And it's a rare lesion, and it's a benign lesion, and it warrants a splenectomy. And that is
partial, he said. Partial also would do.
But this lesion seems to have occupied the entire.
Yeah, depends on the extent, of course.
So, how's the patient doing?
Nice, Dr. Ashwin. That was nice.
Thanks, ma'am. Patient is doing good, ma'am. Now, the patient had if you see this, patient had one more lesion in the liver. This was given as focal nodular hyperplasia of liver 2. So probably we don't know whether the abdominal pain and the presenting symptom is due to this splenic lesion or the liver lesion. So patient is, as of now, is doing good.
How do we exclude IgG4 related disease? Depending on the number of plasma cells, or should we do an IHC to exclude the possibility of IgG4 related disease in this?
Ma'am, it's only with the clinical correlation, ma'am. Many of the literature are telling the ratio will be significant even in SANT.
Okay.
So with the clinical correlation, other radiological findings and serum levels.
Other findings.
Excuse me, please mute your screens. Please mute your screens. There's some child talking. Yes, continue, please.
That's what, ma'am. The IgG4 with the radiological and the clinical findings, we can exclude it. One number, we are not yet to a point where SAN belongs to IgG4 related disease or not. So, but with other the thrombophlebitis are all none of the thing is not seen in the SAN.
So this remains controversial.
There is a set of diagnostic essential criteria, and other criteria which
Mm.
needs to be fulfilled in case we have to call this as an IgG4 related disease. So probably SAN does not fulfill all of them.
Yes.
So it is in the process of being included, but not yet there.
Can be seen in water complex. IgG4 positive plasma cells will be seen in SANT also.
Oh, thank you, Dr. Ashwin. Can we go on to the next case? Dr. Archana, please.
Sure, ma'am. Thank you, ma'am. Good afternoon, everyone.
Yeah, good afternoon, Dr. Archana. You have to share your screen.
I'm not able to share. I think
Dr.
Ashwin has to
Ashwin?
close. He has to
Ashwin,
close
please,
it.
Dr. Ashwin?
I think now it's letting me.
Yeah.
Yes, ma'am. Ma'am, can you see my screen, ma'am?
Your screen is
Okay.
visible and you're audible.
Yeah, thank you, ma'am. Good afternoon. After this list of exotic cases, mine is very simple. Let me put it before I start itself. So basically, this is a 50-year-old woman. She presented with gastric growth, and initial biopsy showed moderately differentiated adenocarcinoma, and it was a locally advanced disease. It was infiltrating liver and spleen and all. So she received 4 cycles of neoadjuvant chemotherapy with capox and 3 cycles of FLOT. And post chemotherapy, there was regression of disease, and then so now operable. So they had done a total radical gastrectomy with D2 lymphadenectomy, distal pancreaticosplenectomy with segmental colonic resection. So this is on the gastric side. Extensive mucosal ulceration was there. Residual tumor was there, patchy. A lot of treatment associated changes were also there. In many areas, it looked very poorly differentiated, like these discohesive, very rhabdoid looking cells. And in some areas, it was cohesive, little plasmacytoid, and cells are very small. And on high power, discohesive, abundant cytoplasm, little foamy cytoplasm, and all those. Gland formation was not seen, and it was infiltrating the spleen, mainly on the capsule. Focally, it was involving the splenic parenchyma as well, as you can see here. And 3 lymph nodes were positive. So as of now, okay, it's probably then mucin stain also came positive. It's probably a residual poorly differentiated adenocarcinoma. Whereas on the pancreatic side, mainly, we started seeing cells like these, which look little well differentiated, which is not looking more like a poorly differentiated adenocarcinoma, pseudoacinar, small nests, and in vague pseudoacinar pattern and all. And it gives us a feel that can it be a neuroendocrine. So initial slides were like, it was seen on the pancreatic side, and the tumor was seen. It was also seen on the pancreatic side. It was infiltrating. So I was like, is it 2 different tumors? Probably a neuroendocrine tumor which was arising from the pancreas, and the residual tumor from the stomach side. Whereas in some areas, these two tumors were closely admixed. In between, you can see these poorly differentiated admixed with nests of these well differentiated cells. Here again, you can see closely opposed to each other. On the left side, poorly differentiated. In some areas, actually, within the same nest, cell nest, some were looking well differentiated and some were looking poorly differentiated. And mucin stain, when we did on the poorly differentiated areas, it came positive, whereas on well differentiated looking areas, it was negative. Since we had a doubt whether it's a neuroendocrine tumor, we just did 3 markers. So initially I was like, is it residual? It is residual poorly differentiated adenocarcinoma. Is it showing a neuroendocrine component? And of course, we need to grade it. It was looking well differentiated. So synaptophysin, as you can see, nicely positive in the neuroendocrine, and adeno, it is negative. Chromogranin, again positive in neuroendocrine and negative. Ki67, as you can see, it's less than 1%. Very rare cells were positive in the neuroendocrine, whereas it is very high in the adeno area. So hence we suggested a diagnosis of Minin, also called as mixed neuroendocrine, non-neuroendocrine neoplasm, wherein we had given a percentage of poorly differentiated adenocarcinoma residual of 65% with a well-differentiated neuroendocrine tumor G1 of 35%, and all the nodes that that were positive showed just adenocarcinoma, and the tumor that was infiltrating the spleen was also adenocarcinoma. The one that was infiltrating the pancreas and the peripancreatic tissue only had the neuroendocrine component, but it was quite significant, around 35%. So previously it was called as MANEC, also called as mixed adenoneuroendocrine carcinoma. It has been renamed in 2020 WHO as MINEN, also called as mixed neuroendocrine non-neuroendocrine neoplasm. So adenocarcinoma has been changed as non-neuroendocrine and carcinoma has been changed as neoplasm. So why the name change? Because other than we have always seen tumors where it not necessarily it has to be adenocarcinoma. We have seen cases where it can be a squamous cell carcinoma or some other carcinoma as well, like for example pancreatic acinar adenocarcinoma, whatever. The carcinoma component can be anything. Similarly, why did we change it as from carcinoma to neoplasm is both the non-neuroendocrine component as well as the neuroendocrine component can be well differentiated to poorly differentiated. For example, the neuroendocrine can be a G1 or a G2 or a G3 tumor, or it can look like a neuroendocrine carcinoma itself. Whereas even the adeno component can be adenoma or a adenocarcinoma, squamous cell carcinoma, or whatsoever. So really, are these composite tumors or collision tumors? It's difficult to say. So there are many proposed theories why these two things come. These are basically theories only. They hypothesize that they may arise independently as synchronous or metachronous tumors, and it's hypothesized that they would have been arising from a common pluripotent stem cell, which virtually shows biphenotypic differentiation. And the other hypothesis is they say they all start from a non-neuroendocrine cell phenotype, but with progressive certain tumor cells, they get more molecular or genetic aberrations, and then they go along the line of neuroendocrine differentiation. And similar things have been described in colon and rectum, especially in post radiotherapy cases. So there also proposed theories are different. They say that radiotherapy induces these tumor cells, and then the tumor cells transdifferentiates to neuroendocrine carcinomas. And they also assume that the neuroendocrine component would have been a minor component, since the adenocarcinoma component is being destroyed by the radiotherapy. So there is more space for the neuroendocrine tumor to grow. So that is another hypothesis, but those two hypotheses applies to colon and rectum neuroendocrine carcinomas, which arise especially after radiotherapy. So what is the clinical implication, especially like, if it's a poorly differentiated neuroendocrine carcinoma, of course, the patient has to be treated with neuroendocrine protocol as well, in addition to adenocarcinoma, which carries a very bad prognosis. What about our case? Because it's very well differentiated neuroendocrine tumor, it's completely resected, the margins are all free. So now in our case, the carcinoma, the residual tumor, the carcinoma is going to drive the prognosis. So how does it matter that the neuroendocrine tumor is? In case if the patient develops some kind of metastasis, for example, a liver metastasis, so if it would have been a carcinoma, we are going to brand them as a metastatic disease and not give them, the treatment is going to be palliative. If the liver lesion is going to show, since we know that now in hand that there is a neuroendocrine component as well, which is a well differentiated, if it is going to be a well differentiated tumor in the liver in future, it can be resected and the patient can be disease free. So how do we follow up is by serum chromogranin levels, first once in 4 months and then once in 1 year and all. The main thing that I came to know about the serum chromogranin levels are, if the patient takes proton pump inhibitors, which many of us do, the chromogranins go to more than 100, it seems. So the patient has to stop taking proton pump inhibitors for 2 weeks at least before taking the chromogranin levels. So they will monitor that, and if there is an elevation with a presence of a new lesion, then they will do a biopsy and see if it's adenocarcinoma or a neuroendocrine tumor, and then treat the patient accordingly. Thank you. Thank you for the opportunity, ma'am.
Thank you, Dr. Archana. So we are having in rare sand and minin, and we're having all new words. I mean, it's not new words, rare words.
Abbreviations, you may call it, Valar.
Madam? The abbreviations, rare abbreviations. It's all a set of rare cases and rare interesting cases we are seeing today. Can we go on to the next presentation, Dr. Divya from Srihar? Dr. Divya and
Yes,
Dr.
ma'am.
Yes, please.
Yes. Ma'am, is my screen visible now?
Yeah, your screen is visible.
Yes. Good afternoon to all. I'm Dr. Divya, senior resident from Sri Chandra Medical College. Moving on to the case, a 60-year-old male patient presented 2 months back with a 3-year history of swelling originating from the right parotid. There was a gradual increase in size, and after that, for the past 3 months, there was a rapid increase in the size. And at presentation, it was a hard rubbery mass. Coming to the radiology, an MRI neck was done. The right parotid gland was enlarged and showed a presence of large, solid, hetero-intense mass lesion measuring 10 by 7.6 by 7 centimeters, involving both the superior and the deep lobes. The areas of hemorrhage and cystic degeneration, necrosis were also seen within the tumor. Following this, a right total conservative parotidectomy with neck dissection of level 2 to 4 lymph nodes was performed. This was the gross of the lesion. We received a skin-covered lobulated mass measuring 14.5 by 12 by 7 centimeter, and skin showed a central depressed area of measuring 1 centimeter. And underneath the skin, we saw a lesion and a lesion measuring 9.5 by 8.5 by 6.5 centimeters. It was a solid and a cut surface showed a solid and a cystic lesion. Mostly the predominant areas were solid, which were formed to soften consistency, and the cystic areas were around 20%, and the wall of the cyst appeared smooth. And focal gray brown areas were present, and myxoid areas were also present, about 5%. This is the histopathology. We can see there are this is the low power view. We can see these chondromyxoid areas, and here we can see some solid areas present. For the high power, we can see that there's a chondromyxoid stroma which is present with myoepithelial cells. And the next picture shows epithelial cells arranged in tubules and cysts. And the solid area, which we saw previously in the low power, this was the solid area, the high power of that solid area where we can see the spindle-shaped cells. These are further sections of the same infiltrative tumor where we can, this is the higher power. The tumor cells were spindle-shaped with elongated nucleus and moderate to scant eosinophilic cytoplasm. These are other areas where we saw, and there was a perineural invasion was also present. And by IHC, the tumor cells were positive for P63. This is the nuclear positivity. Next, we see SMA. This is the SMA which showed a membranous positivity. This is GFAP. And tumor cells were diffusely positive for GFAP. And SOX10 also show nuclear positivity. The Ki67 index was 60% in the tumor. And the lymph nodes examination showed everything was negative for the tumors. All were negative. And based on the H&E and IHC features, we gave the final diagnosis as total conservative parotidectomy, PT3 because the tumor was larger than 4 centimeter, and PN0 as there was no regional lymph node metastasis was present. We gave it as myoepithelial carcinoma X pleomorphic adenoma with margins free of tumor. So moving on to discussion part, just 4-5 slides. Yeah. So it is an epithelial or myoepithelial malignancy. Carcinoma X pleomorphic adenoma is an epithelial myoepithelial malignancy, and it arises from a primary or a recurrent pleomorphic adenoma with peak incidence in the 6th and the 7th decade, and it occurs more often in women, and most common location would be the parotid. And this picture shows a schematic illustration of the development of carcinoma X pleomorphic adenoma as a multi-step progression from the pleomorphic adenoma. So we can see that from pleomorphic adenoma, there's an intracapsular carcinoma develops where there is abnormal proliferation between the existing ducts, and then this further develops into a minimally invasive carcinoma. So a minimally invasive carcinoma, the earlier cutoff was 1.5 millimeter. Now, after many research and everything, they've come to a cutoff of 4 to 5 millimeter in size, and this will further extend into an widely invasive carcinoma. So therefore, we can classify it into carcinoma X pleomorphic adenoma into intracapsular, minimally invasive, and widely invasive. And most cases will be usually a high-grade adenocarcinoma or not otherwise specified. You have salivary duct carcinoma also. Myoepithelial carcinoma incidence is very less comparatively. It is 35%. And if it's an intracapsular carcinoma, ductal and high-grade will be present in that.
Now, the precise preoperative diagnosis is almost impossible, and the risk factors for prognosis is actually uncertain. There are many prognostic factors present. For intracapsular and minimally invasive carcinoma pleomorphic adenoma, we do superficial parectoidectomy is preferred. For invasive carcinoma, it is either a total or radical parectoidectomy is indicated. And infiltration of facial nerve, if it is present, then we do end block resection of the facial nerve along with the removal of the glands. And if cervical lymph nodes are involved, then we do functional modified or radical dissection of the lymph nodes. And post-operative radiotherapy is considered if there is suspicion of any inadequate resection of the tumor, or if it's a high-grade disease, or if there is any invasion of perineural tissues or lymph nodes or soft tissue extension, or a lymphatic or a vascular invasion. And so the presence of the myopathic carcinoma originating from a minor salivary gland has a better prognosis, and the presence of spindle cells may correlate it with aggressive behavior metastasis or distant metastasis. And overexpression of Ki67 is considered as a high risk factor. And there was one study done by Nagao et al., which reported that the patients who had a high expression of Ki67, more than 30%, actually died of the disease. And extraparietal invasion with advanced T stage and lymph node is also associated, lymph node involvement is also associated with poor prognosis. And the progression after detection of any cancer progression or recurrence is associated with a median survival of less than 1 year. Now, these are, in a nutshell, the risk factors. High risk is a spindle cell type. IHC for P53, P63, when it is positive, or Ki67 labeling index is high, is considered a high risk factor. And the size, soft tissue or perineural invasion is also considered as high risk. Low risk is when there is minor salivary gland involvement or when there is a clear cell component. An unknown or equivalent or controversial risk factors would be when it is derived from benign tumor or a pleomorphic adenoma or a myoepithelioma. So in conclusion, Ki67 plays an important role in prognosis, and identification of perineural soft tissue invasion and lymph node metastasis is crucial for further management of the patient. I would like to thank Dr. Sandhya Sundaram ma'am, Bharti ma'am, and Dr. Banu Kirtan. Thank you.
Thank you, Dr. Divya.
Yes.
Any questions, or we can go on? Can we go on to the next case?
Was there any squamous component in this? I thought in one of the sections that was projected, it looked like a squamoid areas with
No,
even keratin pearl formation.
No,
one of
ma'am.
the slides which you had island of it was not.
No,
I don't
ma'am,
know.
there
Maybe.
was no. I am
No,
sure
but
which
one of the
slide.
slides which you projected, I don't know. That island of Musin.
Madam, there was a
this
keratinous
area
area.
with.
There
You
was a
agree, no?
squamous area, madam.
Yeah, that is what I was.
Madam,
There was a squamoid area
yes,
in
yes,
one
yes.
section.
But I thought pleomorphic adenoma can show squamous areas, Ilya.
Yes.
Component.
Welcome. The retinization is common.
Okay, thank you, Dr. Divya. Can we go on?
Thank you, ma'am.
Dr. Muthu Subramaniam?
Yes, ma'am. Can I share my screen, ma'am?
Yeah, please.
Is my screen visible, ma'am?
Yeah, your screen is visible.
Good afternoon, Dr. Muthu Subramaniam from Sri here. I'm going to present a case. Before presenting it, I want to thank Dr. Sandhya ma'am for encouraging us to present at this forum. And I want to thank Dr. Shushwan sir. He is the primary consultant in this case. So this is a 66-year-old multiparous postmenopausal female who came with complaints of bleeding per vaginum for past 2 months. She attained menopause 18 years back, and her vitals were stable, and she didn't have any other complaints. There's no treatment history for this particular complaint in the past, and per-abdomen examination shows a mass which was measuring about 12 to 16 week size, and in per-speculum examination there was a mass which is seen in the cervix, following which she was advised to undergo an radiological investigation. So the first image over the left is an axial section which shows T1, T2 high isointense mass here in the cervix, which is almost obliterating the entire cervix. And this is the fibroid which is there in the anterior aspect. And this is the sagittal section, which we can see clearly here. The entire lesion was occupying the entire cervical canal. The cervical canal is obliterated here, and there is a mass in the anterior myometrium, which is a fibroid. And in the my endometrial cavity, the endometrial cavity also shows a lesion which is about 5.2 centimeters in maximum dimension, which is having a similar type of intensity when compared to the cervical lesion. So the radiological findings were there were an enlarged antevated uterus with a mass in the endometrial cavity, which was measuring 5.2 into 2.3 into 4.4 centimeters. And this mass is seen extending into the cervical canal and involving to upper two-thirds of the vagina as an endoluminal mass, which was measuring 6.6 in greatest dimension. There were multiple enlarged lymph nodes. The right external internal iliac nodes, left external iliac nodes were enlarged. The maximum size was 2 centimeters. There was a fibroid in the anterior myometrium and there was no ascites. With these radiological findings, they gave a probable diagnosis of endometrial carcinoma, following which they took a biopsy from the cervix because they were not able to go into the endometrial cavity because the cervical lesion was entirely obliterating the canal. So this is the histologic section from a cervical biopsy. You can see this entire tissue is infiltrated by neoplastic cells, and you can see some congested blood vessels and this magnification. So this is a hyper view which shows the neoplastic cells predominantly arranged in nests and focal sheets kind of areas, and you can find some vague glandular kind of pattern, some mucin within it. And the higher magnification shows these cells arranged in nested patterns, and the individual cells are large and pleomorphic with well-defined cytoplasmic borders. The cytoplasm is moderate to abundant, which is having a glassy kind of nature. The nucleuses were large, which is having prominent nucleoli. So this high magnification shows a large nucleus with characteristic prominent nuclei. The cytoplasm is glassy in nature. And this area shows these neoplastic cells when being infiltrated by the lymphocytes, and you can find some vague glandular kind of areas also. So we proceeded with the IHC markers. The ER was diffusely negative. The PR is diffusely negative. CEA shows focal positivity. And this is P16, which shows a diffuse block positivity, which is staying in both nucleus as well as in the cytoplasm. So we read out the final diagnosis of glassy cell carcinoma of cervix. Clinically, as the radiology pointed out, there was multiple enlarged lymph nodes. The largest was 2. They staged it as 3B, and the patient has been started with induction chemotherapy, and the patient's follow-up is due. So coming to the discussion part, glassy cell carcinoma of cervix is a variant of poorly differentiated adenosquamous cervical carcinoma, which is associated with high-risk HPV infection, most commonly of HPV-18. So this type is relatively rare because it constitutes about less than 1% of cervical cancers. The patient usually complains of vaginal bleed, and during presentation has a high rate of metastasis. And the mean age is slightly lesser when compared to the conventional squamous cell, which is of 50 years of age group. And in glassy cell carcinoma, the patient usually presents at the age of 45. So grossly or in radiology, it will be having a large barrel-shaped cervix with the endocervical lumen that's been narrowed. So the criteria has been set by Glucksmann and Cherry, who first identified this mixed type of adeno and squamous type of carcinoma. So these are the following points are the characteristic features of glassy cell carcinoma. The cell should be uniform and large polygonal shaped cells. Will be having a moderate amount of eosinophilic cytoplasm. The cell borders will be usually distinct, and the nucleus is relatively large. It should be having a prominent nucleoli. The other features where there can be a rare squamous or glandular element, and there won't be any intercellular breaches, which will be usually seen in squamous cell carcinomas. The mitotic rate will be usually high, and the tumors will be infiltrated by lymphoplasmacytic infiltrates. Coming to the immunohistochemical workups, P63 and high molecular weight cytokeratins will be positive. CAM 5.2, MUC1, MUC2, and CEA is going to be positive, and CEA usually will be focally positive. P16 is characteristically diffuse, shows a diffuse block positivity in all the tumor cells, and K67 will be usually high. ER and PR will be usually negative, and HER2 overexpression can be seen in certain cases, but if it is present, it is going to have an aggressive behavior. Coming to the management part, since glasses cell carcinoma is a relatively rare entity and there's no lack of evidence-based treatment for these particular cases because we don't know at which particular point of time the lesion arises, and there's no pre-invasive or pre-invasive lesions as we see in squamous cell carcinomas. The identification of these lesions only arises when the patient comes with history of vaginal bleeds or something. And the various treatment modalities has been tried up, like surgery alone or radiation with surgeries, radiation with neoadjuvant chemotherapies, etc. So this is a graph which shows the this is a survey graph which shows the glasses cell carcinoma is going to have a poor prognosis, and if it is going to be in stage 1, relatively it is going to have good prognosis when compared to the stage 4. To conclude, cervical glasses cell carcinoma is usually associated with high-risk HPV, the HPV 18, and there is insufficient data in literature, so there's no proper screening guidelines, and there's no distinct cytological features which we usually see in cases of squamous cell carcinomas, and we don't know what are the pre-invasive lesions in this particular entity, and there's no documented evidence of the trium interval from which the lesion progresses from a pre-invasive type to an invasive type, and we lack in proper treatment guidelines. So as of now, the treatment guidelines has been followed, which is similar to that of a squamous cell carcinoma of cervix. The 5-year survival rate is lower when compared to squamous cell carcinomas, and multimodal therapies have been in the thing which has improved the disease-free survival in cases of glasses cell carcinoma. So once the stages of glasses cell carcinoma high, the prognosis is going to be bad. So in our case, it is stage 3B radiologically. So they started with induction chemo, following which they will be assessing the case next week, and if it has been reduced, they will proceed for an radical tracheotomy. So these are my references. Thank you.
Thank you, Dr. Muthu. That was a nice case. We go on to the next presentation. Dr. Punitavati from Stanley Medical College. Dr. Punita? Dr. Punita, are you there? If Punita is not ready, can we go on to Madha Medical College? The next presenter, please.
Yes, ma'am.
Please share your screen, Ma.
Is it visible, ma'am?
Yeah. Dr. Brinda, welcome, Dr.
Yes.
Brinda. Your screen is visible.
One second. This is Dr. Brinda from Madha Medical College presenting a typical case which is diagnosed clinically as epididymal cyst. So this is a case of 46-year-old male presented with swelling in the right side of the scrotum for 6 months duration. He was having a complaint of increased frequency, urgency, and thin stream dysuria, no history of hematuria, and he was known case of hypertension and coronary artery disease. Other systems were normal. And clinical examination, local examination, the clinicians found right testicular swelling and upper pole measuring 3 into 3 centimeter, and it was hard and non-tender. Grade 1 prostatomegaly was also there. And radiological and clinical diagnosis, the final clinical diagnosis made was right epididymal cyst. And grossly, we received a cut open encapsulated oval firm mass, which was measuring 2.8 by 2.5 by 2 centimeter. And cut section shows homogeneous gray white lesion. And on microscopy, it is a well circumscribed, well encapsulated tumor composed of cells arranged in nest and cords of cuboidal to low columnar epithelium with vacuolated cytoplasm, moderate to abundant eosinophilic vacuolated cytoplasm, and the nuclei were very bland, and we saw areas of lymphoid aggregates also. With these findings, we did PA staining also, and it was negative under tumor cells. And the atypical diagnosis, that is adenoma tumor. Adenoma tumor usually seen in the paratesticular region, most common benign tumor, and seen in 3rd to 5th decade, and benign tumor of mesothelial origin, and usually based in the epidermis, and it is well circumscribed and expresses the markers of mesothelial origin. Surgical excision is the treatment of choice. And differential diagnosis as of this bland nuclear structure and vacuolated cytoplasm, does adenomatoid tumor proper. And the metastatic carcinomas, including signet ring cell carcinomas and carcinoma of the reti testis, all were malignant mesothelioma, all were excluded because of the absence of nuclear pleomorphism and ATPM. And sclerosing lipogranuloma were excluded because of the lipid. It was showing mucin in the cytoplasm, not in the lipid lipid stain was negative. And paratesticular yolk sac tumor, it is not showing any primitive tubular structures and all, so it was ruled out. And rare epithelioid hemangioma of the testis also ruled out because it was showing the typical finding of plump. It was not showing the typical finding of plump nuclear features and all. So these are all the differential diagnosis and my references, ma'am. Actually, the radiologic diagnosis made, they were very confirmed that it is epidermal cyst. That's why it was cut open on surgical table itself, and it was sent, and it was showing a typical picture of adenomatoid tumor. Thank you, ma'am.
Thank you, Dr. Brunda. That was a nice case. Can we go on to the last and final presentation? Dr. Punita from Stanley.
Yes.
Dr. Punita.
Is my screen visible, ma'am?
Yeah,
Am I
yeah.
audible?
Yes, ma'am, you're audible.
We will move on to an interesting case of pancreas. First of all, I would like to thank my professor and HOD, Dr. Anurag Ma'am, and all the professors in my college who has given a nice opportunity for presenting a case in this forum. Moving on to the case.
Punita, your screen has to, you have to go to the next slide.
Not moving now. We will move on to the case, ma'am. 52 years female, known case of hepatitis B virus related decompensated liver disease with portal hypertension for 9 years. She has lost a polyp since 2 years, and she was incidentally detected lesion in the distal body of the pancreas. And she was also diagnosed as having diabetes mellitus for 2 months, and she is under treatment. Ma'am, am I audible, ma'am?
Yes, ma'am, you're audible. You can continue.
Triple phase CT showed a homogeneous, solid, well circumscribed mass, which is around 5 × 5 centimeters in the distal body of the pancreas. And by CT, the diagnosis was suspected to be neuroendocrine tumor of the pancreas. They proceeded on with endoscopic ultrasound guided FNAC done in private hospital, and the sphere was positive for malignancy. Then further evaluation was done in Stanley Hospital. They proceeded on with the distal pancreatic splenectomy, and intraoperatively a 5 × 5 centimeter hard mass was noted in the distal body of the pancreas. And we received a specimen of body interior of the pancreas with spleen. So grossly, we received a pancreatic specimen measuring around 4 × 4 × 3 centimeters, and cut surface showed a well circumscribed neoplasm, which is around 3 × 2.5 × 2.3 centimeter. So microscopically, we received normal parenchyma of the pancreas with an adjacent well circumscribed encapsulated neoplasm composed of tumor cells arranged predominantly in bundles and fascicles. The tumor cells are epithelioid, arranged in also nested pattern with the melanoma-like macronuclei, also spindled, both having vesicular nuclei, prominent nucleoli. And am I audible, ma'am?
Yes, ma, you're audible.
Associated with diffuse macrophages and hemorrhages. Here we could see arrangement of spindle-shaped cells around the blood vessels. So, since we had plump epithelioid and spindle-shaped cells, just added on with markers favoring just like CD117, DOC1, CD34 seemed to be negative, KS67 was just 1%, with very low mitotic activity. And since we found spindle-shaped cells having smooth muscle-like morphology, we proceeded on smooth muscle markers. Vimentin, Desmin turned out to be negative. SMA showed strong positivity. CK was done to rule out acidic cell carcinoma, primary clear cell carcinoma. All turned out to be negative. HND45 showed strong positivity, and S100 was negative. Since HND45 and SMA was co-expressed along with K67 less than 1%, we diagnosed or we signed out the report as perivascular epithelioid cell tumor, pancreas. So a few words about PCOMA. It is a soft tissue tumor of the pancreas showing perivascular epithelioid cell differentiation. It may either be benign or malignant. It is an extremely rare case. So far, only 22 cases have been reported globally. It's common in adults more than 30 years of age, showing female preponderance. Risk increases if there is a family history of fibrous sclerosis complex or any genetic predisposition to syndromes like neurofibromatosis 2 and von Hippel-Lindau gene. And our patient doesn't show any association with any of these genetic syndromes. Signs and symptoms are patient may present with anemia, jaundice, pain, abdomen, diarrhea, and melena. The patient may present with either a single mass or multiple nodules in the pancreas. This formation may be seen and it is locally aggressive. So grossly, it might be a vaguely lobulated mass with cut surface showing grayish red solid mass with hemorrhage and necrosis at the center. So microscopy, we can have range of morphologies. Most common is epithelioid cells arranged in nested pattern associated with few spindle cells with smooth muscle-like morphology with granular richness of clear cytoplasm, vesicular nuclei, prominent nucleoli. And hallmarkers, there might be spindle-shaped cells or epithelioid cells arranged around blood vessels. So this is a book picture showing nest of epithelioid cells arranged around the blood vessels and HND45 positivity. So IHC-wise, HND45 and SMA co-expression is the most common one. Melan A can be expressed in 50% of the cases. And if melan A is expressed, HND45 usually is negative. And Desmin is expressed in 25% of the cases. S100 is usually negative, but if present, it is usually cytoplasmic. Also, there can be PFE3 rearrangements. And PAS and PAS diastase is usually positive because of the presence of glycogen positive granules seen in the cytoplasm. So complications, patient may go on for obstructive jaundice, GI obstruction, weight loss, diabetes mellitus, ascites, metastasis to liver or lymph node. So there are certain features that favor malignancy here. Large size of the tumor, there is more than 5 centimeters with infiltrative growth, hypercellularity, high nuclear weight, and mitotic figures more than 1/50 hypophy necrosis. So combination of 2 or more features usually suggest malignancies. So these are the differential diagnoses considered. Primary clear cell carcinoma pancreas, actina cell carcinoma, clear cell sarcoma, pancreatic cyst, melanoma, and metastatic renal cell carcinoma. The primary clear cell carcinoma, there are arrangements of clusters of clear cells with PAs with vacuoles of clear cells devoid of glycogen. So PAs is negative. IHC-wise, NUC1, hepatocyte nuclear factor 1 beta, PK7, 19 is positive, and rest of the neuroendocrine markers with Vimentin is negative. Actinic cell carcinoma, it is a rare malignant neoplasm. It's common in pancreatic head. Men are more common. Grossly, we receive a fleshy mass, and microscopically, we see cells arranged in cystic or acinar pattern with zymogen positive granules. IHC-wise, trypsin and chymotrypsin, pan-city expression is more. Moving on to clear cell sarcoma, it is an uncommon malignant neoplasm with granular differentiation. Grossly, we receive multilobulated, great and firm homogeneous mass. Microscopy shows polygonal fusiform cells arranged in nested pattern with mitotic activity 3 to 5 at 10 hyperfield. And it shows melanocytic markers expression like HND45, melan A, microcapillary induced transmission factor, and Vimentin. Rest of the markers like smooth muscle markers, CD34, 117, synaptophysin granino negative. Moving on to pancreatic cyst, it is the most common mesenchymal tumor of the GIT. It is originated from the interstitial cells of the heart, and it also occurs as an incidental finding while doing the CT. And microscopically, you could see spindle-shaped cells with ovoid blunt-ended nuclei, epithelioid cells, and we can see sphenoid fibers, which are nothing but acyclic aggregates of filamentous material seen around the tumor cells. Here, c-KIT mutation, c-KIT DOG1, S100, CD34, melan A, especially in epithelioid cyst positive. S100 and HND45 is negative. So melanoma is also considered a differential diagnosis since we got HND45 and HND45 positive. And also our microscopy showed melanoma-like macronuclei. It arises from embryonic neural crest cells with highly malignant. Here HND45 melanine and 800 positive. Also, we consider the metastatic renal cell carcinoma showing tumor cell specific clear cytoplasm, which shows CD10 and PAX8 positivity. So these are the panel of markers. So in primary clear cell carcinoma, PAN-CK along with NUC1 and hepatocyte nuclear factor 1 beta is expressed. And in acinar cell carcinoma, trypsin, chymotrypsin along with PAN-CK is positive. And clear cell sarcoma, HND45, melanine is positive along with Weinmann. And just CD117, DOG1, and melanine in case of epithelioid is common. And melanoma, HND45, melanine, and S100 are positive. So management, since PCOMAs are aggressive, surgery is the only option. Chemotherapy and radiotherapy can be done in malignant PCOMAs. The take-home message, PCOMAs should be considered in the preoperative differential diagnosis of pancreatic mass, though PCOMAs are rare. So it's an extremely rare case. So far, only 22 cases have been reported globally. So this is one of my reference journal. Thank you. Thank you for the opportunity given.
Thank you, Dr. Punita. Do we have any questions?
Nice presentation, Dr. Punita. Is it considered, how do you categorize it? Do you do it to consider it as benign or borderline or malignant? Is there any criteria given in the literature?
It's benign only, ma'am. Since the size of the tumor is less than 5 centimeter, and mitotic activity is around 1%.
Yes.
And also we didn't have any high nuclear grade like that. No necrosis.
But actually, no, the criteria has recently changed. That's why I was asking you this question. Initially, it was divided into benign and tumor of unknown malignant potential and malignancy.
Yes,
but now, off late, there is a change in the categorization of such tumors. You don't call them as benign anymore, because those tumors which have been considered as benign initially during the initial few years also has known to have metastasized. So now it is called uniformly as tumor of unknown malignant potential or malignancy. So benign, we do not actually call them as these days. It's changed. And this is for the information of the forum. Anybody can contribute. Yeah.
Thank you. Thank you, Chandra madam, for that valid point. The final so if we have no more questions, then we can close this meet. So we had around 11 cases presented today, and it was an array of cases with rare abbreviations learned. And thank you for the participation. And with Sandhya madam, anything to say, and Chandra madam, we can close.
Thank you so much, Dr. Valar. What an excellent array of cases. And I congratulate all the presenters. They bring in such excellent cases that we learn every session, we learn. So thank you so much to all the presenters. And
I also want to congratulate Valarmati for uninterrupted academic field, I should say. Valarmati, you have done a wonderful job of continuing the pathology meet.
Thank you, ma'am.
You're not able to hear me?
Yes, ma'am. Yes, ma'am.
Yes,
Very much.
Yes, ma'am.
Very much able to hear you, ma'am. Thank you so much. And it's not only, it's all a group, it's all a teamwork, madam. Thank you so much for that, madam.
Yeah, I know. But anyway, you've been the leader person, right? So I think
the main pivotal person,
put
yeah.
a bit of enthusiasm and I agree it is a cooperation from everybody, but even then somebody has to bell the cat, right? So you always ask me as soon as the city pathology meet comes, you immediately talk to me and say, madam, are you putting any case? That is an impetus for us to think of something which is rare or which is something which will evoke some interest in all the budding and the junior pathologists. So I congratulate the city pathology group as a whole.
Thank you, ma'am.
And this should continue, and you should see the 100th meet.
First we'll see the 50th meet, madam. 50th meet.
Hello, Sita.
Beyond.
Yeah, ma'am. 50th and beyond. Yes, madam.
Okay.
We are learning.
Okay, congrats.
Thank you, ma'am.
Yes, ma'am. This being the
11th?
final meeting, we should thank all our senior Sita madam, Eril madam, and many others. And people who contribute. Avi Shanti madam comes in, and our Sare Paul madam, thanking everybody, and thanking Sandhya Sundram madam, Teleflow, and Chandra Shri madam, and thanking all the presenters were kept up with the tempo, ma'am. Thank you so much, and I think we'll meet up in Jan next year, madam.
Yes, Happy New Year, Valet.
Thank you. Thank you. I think we are the first to wish Happy New Year. Yes.
And I can actually think of compiling all these cases, like
definitely. We'll do, madam. We'll do one or two.
Produce a book. Yeah.
Yes, ma'am.
Okay,
Yes, ma'am.
Yes,
thank you.
That would be a wonderful idea.
Yes.
Good.
Thank you, ma'am. Thank you, ma'am.
Thank you, one and all.
We just, we took some more of the time. Usually we finish on time. Now it's just 15 minutes past. Thank you, madam. Thank you so much. Bye, madam. Bye.
But anyway, then these cases will always remember all these cases.
Yes, ma'am. Men and all new organisms. And thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Bye. Bye, Vala.
Bye, ma'am. Bye, ma'am. Bye, ma'am.
Bye.
Bye. Bye.